morning. I had the incredible honor of getting to work with him here at UIC. He's one of our acute leukemia experts, also myeloproliferative neoplasm expert, and we are very, very fortunate that it's been multiple times that he's been able to come here, give us some of the incredible lectures that are many times case-based and really give us an incredible insight into how the field is changing. So Noah, can you please come here?
Thank you, Carlos, for the introduction. Good afternoon, everybody. Can everybody hear me okay? Try to figure out standing wise, where's a good place so you can see the slides still. If I stand here, am I blocking?
There's the TV right here's the video.
Okay. So today I'm going to talk to you about triplet drug regimens and AML. I think the program suggested in the relapsed refractory setting, but I think there's some really exciting data that also shows some progress in emerging therapies in the frontline setting as well that I'd like to touch on. So here's my disclosures. In terms of deciding AML treatments, we usually try to stratify patients based on the patient and their disease. I like to think of personalized or precision medicine in the context of asking the question, what patient has what disease, and trying to pair the disease with the best treatment for that patient. And really, for that, we need to consider the patient factors of age, their fitness, and their comorbidities that will impact their ability to safely tolerate treatment. And then look at the AML risk factors, specifically the genetic factors that will predict their prognosis and response to treatment. As we know from updated ELN risk stratification, it is now the genetics or the molecular features that help to decide overall prognosis and response to treatment, categorizing the AMLs into favorable, intermediate, and adverse risk based on certain molecular features, with the core binding factors, translocations in H21 and version 16, NPM1 isolated mutations being good risk or favorable disease, intermediate being FLT3 mutated, KMT2A rearrangement, specifically translocation 911, and then a normal karyotype. And then the other molecular changes, specifically a complex karyotype and other KMT2A rearrangements, mutated TP53, as we all know, being adverse risk. And when we look at NCCN guidelines, for those who are fit and capable to undergo intense induction, there are several different regimens that we can choose based on their molecular features. Up top in favorable risk, we can do standard induction with 7+3 and anthracycline with cytarabine, and you can add gemtuzumab ozogomycin or a triplet regimen as already approved and established, being quite effective. Another combination regimen would be for intense induction would be FLAG-IDA with or without gemtuzumab ozogomycin for good risk, favorable risk AML. Standard risk for intermediate standard treatment would be 7+3 alone. And then you go further down if you have a FLT3 mutation, adding on midostaurin to induction, or quizartinib would be reasonable options for your intense induction. However, I would like to focus more on this talk on those patients who are not fit for intense induction for whatever reason, due to comorbidities, fitness, age, and taken all together. There are other regimens that we would consider, in particular, if they have targetable or actionable mutations in IDH1. You can do a combination of azacitidine, a hypomethylator, with venetoclax, as was shown in the VALI-A study, or you can do azacitidine with ivosidenib. For those patients who do not have a IDH1 mutation, you can do azacitidine with venetoclax alone, or you can do decitabine with venetoclax. So there's well-established backbone of doublet therapy for less intense induction for AML. And as I mentioned, that backbone is a hypomethylator agent, either azacitidine, usually given over 7 days, or decitabine, given over 5 days, in combination with venetoclax, a selective BCL2 inhibitor, which for the FDA indication is given over 28 days as oral agent. The VLE-A study was a phase 3 study for newly diagnosed AML, where they compared the combination AZA plus ven, and you had complete remission rates of 66.4% and a median overall survival of 14.7 months with the doublet, as compared to the single agent azacitidine with complete composite complete remissions of 28.3% and a median overall survival of only 9.6%. So based on this, the combination doublet therapy became the standard of care for less intense induction. And this is really the backbone that we are looking to build on and say, can we do even better than a well-tolerated doublet? This is a publication that came out earlier this year from the Beat AML study across multiple institutions in the US, looking at AMLs of different phenotypes. In the Beat AML study, you can see they're looking at specifically patients over the age of 60 with a range of 60 to 92, a mix of Hispanic, but mostly non-Hispanic white patients, 78%. A mixture of normal karyotype at 36%, some complex karyotype adverse risk 30%, 2% have the KMT2A rearrangement. And when we look at the mutational profile of patients in this Beat AML study, the majority of the patients, 28%, had either an IDH1 or 2 mutation. Some had a hypomethylator or changes in DNMT3A affecting DNA methylation, TP53. Specifically, actionable mutations of interest with the IDH1 and 2, FLT3 mutations about 21%, and then PM1, which hopefully in the pipeline there will be some actionable menin inhibitors, represent about 20% in the Beat AML study. And graphed out on the left as a image would be the distribution of the mutations. In the graph, they split up IDH1 and 2. When they're lumped together, they make up about 28% as the most commonly mutated. When you split them out, which is important because the therapeutic targets we have are different for both agents. FLT3 is more common, followed by NPM1, then IDH2, and IDH1 being the least common actionable mutation that we currently have identified and have a therapy for. So we'll turn first to FLT3 positive AMLs, where we see FLT3 mutations in either ITD or TKD domains in about 20 to 30% of AMLs. There are targeted agents that have been FDA approved for induction in combination with cytotoxic chemotherapy. Those would be midostaurin and most recently quizartinib. And in the relapse refractory FLT3 positive AML setting, we have single agent gilteritinib. This received FDA approval off of the Admiral trial, which is a phase 3 trial as a single agent, where a median overall survival was demonstrated at 9.6 months with gilteritinib versus 5.6 months for physician's choice of salvage chemotherapy. So turning to emerging triplet therapies in FLT3 AML, there is a small study in the Beat AML subgroup looking at the combination of gilteritinib added to decitabine and venetoclax that showed a composite complete remission rate of 61% in a total of 18 patients. Of note, there was significant dose-limiting toxicity and neutropenia in the triplet combination at the standard 120 milligram dose, suggesting that perhaps to make this a viable triplet regimen, there may need to be dose reductions from standard 120 milligrams when combined with decitabine and venetoclax. Another small study by Short et al. Looked at gilteritinib with, instead of decitabine, they looked at azacitidine and venetoclax in newly diagnosed AML patients versus a relapse refractory cohort. In the newly diagnosed AML, there's a composite complete remission rate of 96%, which is quite remarkable, with a median overall survival that was not reached and a median follow-up of 19.3 months. Of note, 90% of those responders that achieved a composite complete remission, 90% achieved a negative MRD by PCR, which is really remarkable for a combination, a triplet combination that is feasibly less intense, but does not mean less effective. So a patient who may be less fit, old, may want to avoid an intense chemo regimen. This may be a viable option going forward. Looking at a cohort of relapsed refractory AML patients receiving this triple combination of gilteritinib, azacitidine, and venetoclax, there was a composite complete remission of 27%. It's not nearly as impressive as 96%, but again, we're talking about a relapsed refractory cohort of previously treated patients. And these patients too were limited in their therapy by neutropenia, suggesting that the standard 120 milligram dose in the relapsed refractory setting, these patients may be heavily treated with 2 or 3 prior lines of treatment, more sensitive. It didn't quite rebound, recover their counts as quickly. So in summary, for combination therapies in FLT3 positive AML, FLT3 ITD and TKD both confer intermediate or probable poor risk AML for which we need improved therapies. Single agent gilteritinib is currently approved in the relapsed refractory AML setting, but from that ADMIRAL trial, we know has limited outcomes and still is associated with poor prognosis despite having a single agent targeted therapy. In an early subset analysis from the BEAT AML study in phase 1/2 trials by Short et al., gilteritinib in triplet combination showed promising results, where newly diagnosed AML patients show a better response to triplet therapy than relapsed refractory AML, and both had a dose-limiting neutropenia. And authors suggested that dose reducing from 120 milligram standard dose to 80 milligrams may make this a viable triplet combination that can be well tolerated in these patients. We'll switch over to IDH mutated AMLs. We know that IDH1 or 2 mutations occur in about 15 to 28% of AMLs. As you might recall from your Krebs cycle in biochemistry, IDH converts isocitrate to alpha-ketoglutarate. When you have a pathogenic IDH mutation, you have disruption of this conversion that leads to accumulation of 2-hydroxyglutarate. And this in turn causes hypermethylation of the genome and increases sensitivity to BCL2 inhibition. And that's the implication for why perhaps venetoclax works well in these patients. There are 2 currently FDA-approved IDH1 inhibitors, ivosidenib and olutasidenib, and 1 IDH2 inhibitor, enasidenib. The AGILE trial for newly diagnosed IDH1 mutated AML looked at azacitidine plus ivosidenib. In the doublet combination, there was a complete remission rate of 47% and a median overall survival of 24 months versus single agent azacitidine, where only a complete remission rate of 15% was achieved with a median overall survival of 7.9 months, which allowed the FDA approval for the combination of azacitidine with ivosidenib in IDH1 mutated AML. You compare this to what I showed previously, the ADMIRAL trial with AZA and VEN, there was a significant difference in the median overall survival for these patients seen in a single agent azacitidine group. Single agent median overall survival was 2.2 months versus 7.9 months. So it's certainly between, you can't compare them head to head, but this does show that there's variability between clinical trials and perhaps populations of patients that are enrolled in the trial. Molecular makeup, heterogeneity, ethnicity, comorbidities may have played a role. So important to take that into consideration when comparing single agent or doublet combinations in trials that are not designed to be head to head. Overall, the azacitidine ivosidenib combination showed lower febrile neutropenia rates than were reported in the ADMIRAL trial for azacitidine venetoclax at 28% versus 42% the combination of venetoclax and azacitidine, suggesting that perhaps if you're trying to avoid febrile neutropenia and associated complications, that this double combination may be a place to start for building up a backbone. And as we should be reminded, there's association of differentiation syndrome we have to watch out for with the IDH1 and 2. That's background about IDH inhibitors, 1 and 2. Now I'd like to talk about emergent triplets, trying to incorporate inhibition of IDH 1 2 mutations. There's a recent phase 1b/2 study of IDH1 mutated AMLs combining with venetoclax either 400 or a high dose 800 milligrams of venetoclax. There was a composite complete remission rate of 85% using venetoclax 400, and in a small population of 6 patients, 100% achieved a composite complete remission rate of using venetoclax 800 milligrams. The triplet combination did show an increased rate of incomplete complete remissions due to heme toxicity, so persisting cytopenias with the triplet combination at both doses, the 400 and 800 milligram dose. On the graph on the bars on the right here, the third and fourth graph are your triplet combinations. In blue is your complete remissions and your complete remissions with incomplete recovery in the orange above. And not necessarily surprising, you see increase in incomplete recovery of counts with the higher dose of venetoclax, suggesting that maybe you're seeing in 6 patients increased response rates. Perhaps that's at the expense of some increased cytopenias that may be prolonged and perhaps open up the patient up to some toxicities long term. At ASH, the annual meeting in 2023, there was a phase 1b/2 study of IDH mutated AMLs in combination with venetoclax in the oral combination decitabine with cedazuridine in newly diagnosed or relapsed refractory AML. And there were quite remarkable response rates in a small number of patients, 24 with newly diagnosed IDH mutated AML, of which 90% had a composite complete remission in IDH1, and in IDH2, 100%, 14 patients of 14 achieved a composite complete remission. And in the relapsed refractory setting, while not as remarkable, I think still at about 44 or 50% having an all oral combination, having 50% response rates is quite impressive when you're thinking about unfit patients who are not able to tolerate intensive induction, and perhaps thinking about moving this treatment for AML to an outpatient setting, even in the communities where community providers could be more easily managing, not requiring inpatient chemotherapy, more frequent 5-7 day visits back to back for IV infusions of azacitidine or decitabine. Another phase 1b/2 study, this time with IDH2 mutated AML, looked at the combination azacitidine, venetoclax, and enasidenib. In this study, 57% of patients with newly diagnosed AML achieved complete remissions. All of these patients that achieved complete remissions were MRD negative. So quite remarkable with this triplet combination. And in the relapsed refractory setting, again, as we've seen with all the other studies, not as high of a response rate in the relapsed refractory setting, but 22% of patients who had previously been treated were able to achieve a complete remission. Both achieved a negative MRD. So those that are going to respond are going to have a durable response. This triplet combination also was associated with febrile neutropenia, as we've seen with the other combinations, and also in elevated bilirubin levels. So in summary, for the combination therapies for IDH1 and 2 mutated AMLs, IDH1 mutated patients have lower median overall survival rates compared to IDH2 mutated patients when treated with AZA and venetoclax, as seen in the VALIATE trial. And overall, these patients may benefit from improved treatments, perhaps targeting specifically the IDH1/2 mutations. Dosing of venetoclax in the triplet combinations may impact overall survival and rates of adverse events, as seen with the standard dose of venetoclax 400 milligrams, or even trying to increase that dose to 800 to see improved response rates in doublet or triplet regimens. There's increased rates of triplet combinations and hematologic toxicities and febrile neutropenia that have been observed in triplet combos. So I think we have some work to do to carve out how we can safely combine these drugs to allow patients to safely tolerate but achieve those impressive response rates. So future considerations in triplet combinations for AML is looking at head-to-head studies. Currently, the FDA approval for gilteritinib is a single agent, relapsed refractory setting. But it might be interesting to compare those to patients who relapse and get treated with a combination gilteritinib, venetoclax, and azacitidine to determine if there's overall superiority in response rates and tolerability, safety. If you have more durable remissions by adding the doublet of HMA and venetoclax to gilteritinib, and can it be safely managed? Emerging therapies in KMT2A rearranged AML are menin inhibitors, which also show efficacy in NPM1 mutated AMLs. These are also orally available agents targeting the menin interaction. That's been critical for hematopoiesis and proliferation. It will be interesting to see similar combinations with hypomethylators in venetoclax with the menin inhibitors and how we can safely tolerate the combined toxicities. I think critical to all this is looking at the backbone of HMA and venetoclax in choosing the optimal dosing and regimen for venetoclax. As seen in the one study using venetoclax 400 versus 800 milligrams. Reducing venetoclax, many of us in our induction regimens for AML, while the FDA approval is for 28 days dosing of venetoclax, many of us are decreasing that to 21 or 14 days. So in setting up new clinical trials, it will be difficult to get the FDA approval to adjust two drugs. You're adding another agent to a FDA-approved combination. So I think really trying to convince the FDA that perhaps we're overdoing it rather than decreasing the dosing of a FLT3 IDH or menin inhibitor. Perhaps we know venetoclax is a very powerful drug, and maybe if we can set up regimens that are 7 or 14 days to limit the hematologic toxicities from venetoclax will allow us to squeeze in a third regimen or a third agent for triplet combinations. And finally, looking at co-mutations, we know that while AMLs and leukemias in general are not as heterogeneous as our solid tumor counterparts, there are some co-mutations that are commonly co-occurring in red here. And it would be interesting to understand, are there targeted agents that could eventually combine to treat patients that have, say, both FLT3 and NPM1 mutation, or IDH 1 or 2 mutations in combination with FLT3. So when the co-mutations are present, should we be sequencing the therapies as most commonly the practice today? How do you choose which one to target first? FLT3 followed by IDH 1 or 2, eventually if there's NPM1 targeted therapies with these menin inhibitors, where do you squeeze those in the sequencing of co-mutations? Or are there going to be novel triplet regimens that don't just rely on the backbone of an HMA and venetoclax, but instead 2 targeted agents with something like venetoclax or a hypomethylator, seeing how we can make those quite effective, or if we want to lean into our myeloma colleagues who are doing quadruplet therapies now, who could do the double backbone and target 2 therapies, but it's going to take a lot of tailoring of the dosing specific regimen. So ultimately, we still need to prove that there is a benefit in triplet therapies that show high response rates and allow us to bridge the patients, potentially if they were unfit or had comorbidities. Once we get their fitness improved, because we have the leukemia under control, can triplet regimens be a bridge to a transplant that the patient wasn't previously eligible for? Or really for those truly unfit patients based on age, comorbidities, their functional status, can a triplet combination improve or prolong survival? It can improve their quality of life, spending more time out of the hospital, spending time in the community rather than driving an hour or 3 hours to a local academic center, and allow them to stay closer to home, out of the hospital, where they can really benefit and enjoy the quality. So with that, I'd like to thank you guys for listening, and I'll take any questions you might have. Overall, I think it's a really exciting time, I think, to have new targeted therapies that are coming out. I think we only have a handful of truly targeted oral agents. I can see in my career, hopefully with a lot of exciting biomedical research progress that we're seeing, hopefully we'll be able to target other mutations and have similar questions of what would be a cool backbone from the triplet or even quadruplet therapies going forward. Yeah. Yeah. Any difference in FLT3 to AML with midostaurin, and what was the other part? Sorry. Any difference in the three FLT3 inhibitors? Midostaurin, and quizartinib. Yeah, quizartinib, and then gilteritinib. Unfortunately, we don't have head-to-head studies for the gilteritinib, which is approved in the relapsed refractory setting. And then the quizartinib and midostaurin aren't head-to-head. Overall, it seems that they're both quite effective. Both quizartinib and midostaurin do have the concern of QTc prolongation as a black box warning. So I think those that have cardiac issues, something they should have to consider and watch very closely. But I think the data is still young, and I think I've only used quizartinib a couple times personally. So in terms of my personal experience, I haven't seen big differences in terms of one's better than the other. I would say perhaps somebody has more of a cardiac history. I may go with midostaurin because it's a little bit more established and more familiar. But I think we don't have data that say one is necessarily better than the other. All right. Thank you, everybody.
So we're a little ahead of schedule, which is never a bad thing. We're gonna go ahead and break now. The product theater downstairs, we will start on time then at 3:35. I will come up and tell you guys when we're getting ready to start, so that you can come down and join us. And then whenever the product theater is done and concluded, we will come back, and for our online participants, we will put up a notice once we know what time we're going to be ending that presentation downstairs. And you are also able to participate as well if you just want to hang on. So anyway, thank you guys, and we'll see you downstairs around 3:35. Well,